Welcome, guys. My talk's on ultrasound guided femoral nerve blocks. If you guys came to my morning talk, there's going to be some overlap, no disclosures, and we can get right into it. So I think this is really something that's fascinating. We've been doing this for about 10 years. I've been actually doing this physically on patients for 10 years. And now Stanford, Kaiser, Northern California makes this a protocol for all their patients with hip fractures that come in up front, have to get it blocked in under 2 hours. This is standard practice. And I think it's really interesting because I want to talk about why this is useful, how it's useful, and how you can implement it in your practice. So I think this is emergency medicine at its best, right? This patient, 80 years old, comes in with a fracture. In most hospitals where I work, where other people work, they sit, they get opioids, and they go to the floor. They get watched. They have urinary tract infections. They have outcome badness, right? And this is what we do as a whole. This is all of us. We improve care for patients. And this is the population I want to take care of, right? The people that don't have champions. Orthopods aren't running downstairs and talking about pain control in your 80-year-old hip fracture. So I think this is really where we're at, and we're already starting it, right? We're all hearing the ketamine, the opioids, the NSAIDs, the multimodal pathway for pain control. Here's another one that you can do and you can be good and feel good about. So I think this is really where we're at. This is the pathologic fracture that comes in the middle of the night. This is not cool. This is our chance to make a difference, improve downstream effects, and really cutting-edge medicine. That's why you went into this. Nobody went into this to push the admit button. None of us, I guarantee you. So let's talk about what it is. So anatomy and innervation, we all know basic anatomy. This is great anatomy because we already know it. We put femoral lines in all the time. Nerve, artery, vein, we know this. So if you look, the innervation is pretty much the entire anterior leg, all the way to the knee. Surgeons or anesthesiologists use it for arthroscopy of the knee, so it works almost all the way down. It's a great block, easy to do, and completely covers that region. Great for hip fractures, femur fractures. I call this the Highland hip fracture because we don't have the 80-year-old ladies. We have a lot of gunshot wounds. Large lacerations. If you want to do it for abscess and drainage of the anterior thigh, you can do it. It works really well. It's easy, and I'm going to show you how simple this is. So always when you set up ultrasound machines, it's always contralateral to what you're doing because you want to look. The last thing you want to do is do this, right? Nobody wants to be sticking a needle when they're looking behind them. Have the machine contralateral to you in your view of sight. You want to be able to look at it and be comfortable. Again, you can see probe markers facing out, nerve, artery, vein. That's all you're doing. You're in that angle in the groin where you put that femoral line in. That's all you're doing. Again, this is the schematic for it. And what's beautiful about this, you already see the femoral artery, the vein, and that muscle, that iliopsoas muscle. What's great about that muscle, it's a great landmark for the fascia iliaca. And the fascia iliaca is the key to this block. It's not about the femoral nerve. That fascial plane hugs that nerve and pushes it down. So my goal is not to put a needle into the nerve. My goal is to open that fascia. Once you open the fascia, fluid tracks. Necrotizing fasciitis, that thing goes on a super highway, right? It slides in that fascial plane. Once you get fluid in the fascial plane, it will go. That's all you have to do. So here's some examples, really simple. Artery, vein, iliopsoas. You can see that nerve bundle is right here. There's probably fat around it. This is the fascial plane. You get the needle underneath that fascial plane and inject, you're done. Pain relieved, walk away, hands in the air, right? Other side. There's the artery, there's the iliopsoas muscle, and you see that triangle, that pattern recognition comes into play. There's that fascial plane. You get underneath that, aspirate, inject, open the space up. And I'll show you some examples. This is in the handout if you want. It supplies for this. It's on our website. It's really simple. You need about 20 cc's of lidocaine or bupivacaine. I recommend lidocaine for first-time users just because of the toxicity of bupivacaine. But really not hard. You can use a spinal needle for big patients. You can probably get away with just a 25-gauge needle in small patients. And again, you're seeing, I'm doing this on one of my residents. Machine's contralateral, and then the needle's going to go in plane. You're going to visualize the needle all the way through. And I'll show you some examples. Again, here's your fascial plane. Drops down here. All I want to do is get underneath it. Once I inject, I'll open the space up. Needle's up top. You can clearly see the needle visualized as it comes in. They break that fascial plane, and he slowly adds anechoic fluid to bathe the nerve. Step back, give 15 minutes, and it'll work. The beauty of this is it's really that easy. I can walk a person to 2 or 3 of these, and they can be comfortable doing them. They're not that hard. I'm going to show you some more examples. We're going to the other side now. Again, same anatomy, right? Artery. There's your nerve complex. There's that muscle, which we never talked about, the iliopsoas. Again, the fascia iliaca wraps it down. It's all it's doing. So again, here's a schematic for it. You can see artery, and there's that nerve, and there's that fascial plane that wraps over. All you're doing is getting underneath that fascial plane. Once you do it, you have a pathway to the femoral nerve block. Again, here's another patient. There's your artery. I hope you're seeing pattern recognition. You break underneath that, and you're done. Slow injections, gets closer to the nerve than I like, but still, it could easily get into that space. Actually, this is all fat up here. This is normal fat that's around your femoral nerve, and it allows you to move comfortably. So here's his nerve down here. He's injecting. Good block. So key points. 1, get underneath that fascial plane, and 2, stay away from the nerve. And I'm going to show you an example of when I say get under the fascial plane. Here, my resident's above the fascial plane. You see that? He's injected a little air. I say just go a little deeper. He pops underneath it. He has the block. And that's all you're doing. This is a 25 gauge needle at the bedside. Reduce the pain 50%, 75%, I don't know. So again, emergency medicine is all about this. It's all about doing stuff and making a difference. It's all about pain management, and it's really all about optimal care. Thanks.
Great, thank you.